Okay, so today's topic is non-steroidal anti-inflammatory drugs. In short, NSAIDs. Okay, these are one of the most commonly used drugs in dentistry practice. As you all know, one of the most common symptom or one of the most common problem that a patient presents with in dentistry is toothache. Okay, so not only do we find the cause of the toothache, but what we do is at the end we do treat that pain. We try to alleviate or remove that pain component of the toothache. Okay, so that toothache problem, that pain problem is relieved by one of the group of drugs that are known as non-steroidal anti-inflammatory drugs, also known as NSAIDs. So introduction. Now, these are a class of drugs. They have all the members of these group have three common properties, which include analgesic, antipyretic, and anti-inflammatory effect. Now, how do they differ from the other analgesic drugs? The other analgesic drugs include opioids, that is morphine-like analgesics. They differ from morphine or morphine-like analgesics is that they do not depress the CNS. Okay, that is for their action, they do not depress the CNS. They act peripherally for reducing the pains. They do not produce. Another point of difference from opioid like or morphine like analgesic is that they do not produce physical dependence and they have no abuse liability. That is, they have no potential to produce addiction, and they are very much effective in removing the inflammatory pain, that is the pain associated with inflammation. They are also known as aspirin like analgesics. Okay, they are known as aspirin like analgesics. Next is classification. That is, how do we classify the members of this group of drugs? See, the aspirin was the first member to be discovered and used clinically as a analgesic anti-inflammatory drug. The rest of the members were discovered later on. So aspirin is always taken as a prototype drug. And broadly, these groups are classified as non-selective COX inhibitors. The COX is the short form of the enzyme cyclooxygenase. Also, these non-selective COX inhibitors, they are known as traditional NSAIDs. This group includes many subgroups. They are classified chemically like salicylates. So salicylates have salicylic acid as their chemical composition. It includes aspirin, diflunisal. Then you have the propionic acid derivative, ibuprofen, naproxen, acetic acid derivative. You have diclofenac, aceclofenac. Then you have phenamic acid derivatives, mefenamic acid, pyrrolopyrrole derivative, ketorolac, etodolac, uh, oxycam derivatives, piroxicam, meloxicam, tinoxicam, and finally indole derivative, indomethacin. The second group is the preferential COX-2 inhibitors. Now we'll see in the next few slides that the COX has two isoenzymes, that is cyclooxygenase has two isoenzymes, type 1 and type 2. These group of drugs, they prefer COX-2 over COX-1, so they inhibit COX-2 more as compared to COX-1. Includes meloxicam, nabumetone, nimesulide. Then you have selective COX-2 inhibitors, that is they only inhibit the type 2 isoform of the cyclooxygenase enzyme. It includes etoricoxib, lumiracoxib and rofecoxib. And finally, the last group is classified as analgesic antipyretic drugs with weak anti-inflammatory action. These include paracetamol, this includes nifopam. Okay, now these drugs, the only difference from the previous groups is that they have weak anti-inflammatory effect. So next, we will study first the mechanism of action and pharmacokinetics as well as adverse drug reaction. Now here, aspirin is the prototype drug that we have that I've already told. So we'll study all the effects of aspirin. Please remember that mechanism of action of all the members of this group remains the same. So it is just similar to aspirin. Now, cyclooxygenase, or in short COX, is the enzyme which is responsible for the biosynthesis of prostaglandins, PGs or prostaglandins. We all know that prostaglandins is one of the most important mediator of it is one of the most important mediator of inflammation. So wherever there is any inflammatory process in the body going on, there is a large production of prostaglandin taking place at that particular site, and these prostaglandins are involved in the symptoms and signs of inflammation, which includes pain, local increase in temperature, then inflammation at the local site, tumor, rubor, calor, and dolor. So all the four characteristic features of inflammation, that all four features, these are produced or mediated by prostaglandins. So if we inhibit the production of prostaglandins, all the four features of inflammation, they will reduce or subside or go away. And as pain is one of the components of inflammation, inhibiting prostaglandin synthesis will definitely lead to reduction in pain or produce analgesia. So two types of COX are there. We already discussed that COX has of two isoenzymes, COX-1 and COX-2. Aspirin and all traditional NSAIDs, they inhibit COX enzyme and thus inhibit the generation of prostaglandin. So very simple mechanism of action. They inhibit COX enzyme and thus they inhibit synthesis of prostaglandins, and thus they inhibit or they suppress inflammatory process. So what are the pharmacological actions? First and foremost is its analgesic effect. NSAIDs, they are mainly used for relieving musculoskeletal pain, dysmenorrhea, and pain associated with inflammation or tissue damage as occurs in toothache. Okay, as which occurs in toothache, that is relieved by aspirin. Analgesic effect is mainly due to peripheral inhibition of prostaglandin production. So that is very simple. It increases the pain threshold by acting at a local site. Again, there is no tolerance to its analgesic action. There is no sedation produced by its analgesic action, and there is no physical dependence or abuse liability. Antipyretic effect, yes. So the thermoregulatory effect, that is the center of regulating body temperature, is located in the hypothalamus. Fever occurs due to disturbance of these hypothalamic thermostat, which occurs in inflammation. So any inflammatory process is usually associated with increase in body temperature known as fever. So NSAIDs, by inhibiting prostaglandin production, they reset the hypothalamic thermostat and bring down the body temperature when it is elevated. Okay, so they have antipyretic effect. Please remember that NSAIDs do not lower the body temperature in normal individuals. That is, they do not produce hypothermia. Okay, they only reduce body temperature when it is rise due to inflammation and whenever there is pyrexia. So antipyretic effect is mainly due to inhibition of prostaglandin synthesis in hypothalamus. Anti-inflammatory effect, this effect, it produces all the symptomatic relief that happens whenever there is inflammation going on. They do not affect, please remember, they do not affect the progression of the disease. They only provide symptomatic relief. So you must find out the cause of inflammation and try and remove that cause of inflammation. These drugs, they only provide symptomatic relief. The underlying pathology or the underlying process of inflammation goes on as it is. It mainly decreases the inflammation by inhibiting the production of prostaglandin biosynthesis. It suppresses all the signs and symptoms of inflammation, that is tumor, calor, dolor. Tumor means swelling, dolor means pain, calor means increase in temperature. Okay, rubor means redness or increase vasodilation to the local area. All the signs and symptoms of inflammation are reduced. Next is its effect on the platelets. Okay, aspirin in low doses irreversibly inhibits, just a minute. Okay, so next is its antiplatelet effect. Aspirin in low doses, that is in the 75 to 325 milligrams per day dose, it irreversibly inhibits the platelet thromboxane A2 synthesis and it produces antiplatelet effect. Now this effect is only seen with aspirin. All other NSAIDs, okay, all other NSAIDs, they do not show this inhibition. Okay, the reason is very simple. Aspirin irreversibly inhibits cyclooxygenase enzyme. Please remember that aspirin is the only NSAID which irreversibly inhibits COX, while all other NSAIDs, they are reversible inhibitor of cyclooxygenase enzyme. Okay, so this is the basis of difference between aspirin and other NSAIDs. Also remember that this antiplatelet effect is the basis of its clinical use in many of the cardiovascular disorders. Okay, so you can see that for this antiplatelet effect, the low dose of aspirin is preferred. You can see that low dose aspirin, say for example 75 to 325 milligram, it only inhibits thromboxane 2. Thromboxane 2 causes vasoconstriction and promotes platelet aggregation. While when you give aspirin in its routine analgesic anti-inflammatory dose, which is 2 to 3 grams per day, it not only inhibits thromboxane 2 synthesis, but it also inhibits the protective prostacyclin synthesis. Prostacyclin causes vasodilation and inhibits platelet aggregation. So in analgesic or anti-inflammatory dose, its anti-platelet effect is not manifested. It is only manifested when it is given in low dose, because at low dose it inhibits only this biosynthesis without affecting the protective prostacyclin biosynthesis. And mind you, this effect is only seen with aspirin. It is not seen with other NSAIDs. At high doses, biosynthesis of both prostacyclin and TXA2 is lost, and thus antiplatelet effect is also lost. Acid base and electrolyte balance. In therapeutic doses, salicylates cause respiratory alkalosis, okay, which leads to compensated by excretion of more bicarbonate, that is more alkaline urine is excreted, leading to compensated respiratory alkalosis. Now, if still higher doses are given and all these compensation has already been done, then it can lead to respiratory acidosis followed by uncompensated metabolic acidosis. So basically, in high doses, aspirin has a potential to cause derangement of acid base and electrolyte balance. On cardiovascular system, prolonged use of NSAIDs can lead to sodium and water retention. Now this problem occurs with all kind of NSAIDs. Okay, so it has to be used cautiously in patients with low cardiac reserve, as it may precipitate congestive cardiac failure. So this is one of the limitations of aspirin. So it decreases the effect of antihypertensive drugs. Any NSAIDs when prescribed, it may decrease the effectiveness of antihypertensive drugs. Next is its effect on stomach, that is on the GIT. NSAIDs irritate the gastric mucosa and produce nausea, vomiting, and dyspepsia. Now this forms the basis of its toxicity. Okay, one of the bases of NSAIDs adverse effect is its effect on stomach. Now you can see that aspirin acts on stomach as well as on the CTZ. This is CTZ, chemoreceptor trigger zone. So it produces nausea, vomiting, and dyspepsia. Now how does it produce toxicity on stomach? So it is given here. Aspirin, they inhibits the synthesis of prostaglandins in the gastric mucosa. Now we all know that the prostaglandins in the gastric mucosa, they are protective in nature. That is, they inhibit acid secretion and they form a protective layer over gastric mucosa. They prevent the formation of peptic ulcer. So once the prostaglandins are inhibited in the gastric mucosa, it leads to increase in sodium gastric acid production, that is hydrochloric acid, loss of protective action. All things leads to gastric irritation and peptic ulcer. Another thing is the aspirin, which is salicylic acid, which is a weak acidic drug. In the acidic pH of stomach, it exists in unionized form. Okay, so this unionized form crosses the stomach barrier easily. It enters the gastric cells, it enters the mucosal cells, where because of the alkaline pH, this weakly acidic drug ionizes. It forms ionization and it becomes indiffusible. So this form of indiffusible form of drug remains in the gastric mucosa, gastric mucosal cell, causes damage to the gastric mucosa, producing ulcers, erosive gastritis, and hemorrhage. So these are the this is the basis of adverse effect profile of NSAIDs on gastrointestinal tract. Next is the adverse drug reactions of the NSAIDs. Now I've shown here the adverse drug reactions of aspirin, but majority of the adverse drug reactions are followed by all other NSAIDs. So first and foremost, the most common side effect of NSAID is on the GIT, as I have shown in the previous slide. It ranges from nausea, vomiting, dyspepsia, gastric epigastric pain to acute gastritis, ulceration, that is peptic ulcer formation, and GI bleeding. Ulcerogenic effect is the main drawback of NSAIDs. Now, this is the most common problem encountered with the prolonged use of NSAIDs, and this is the main drawback of using NSAIDs as an analgesic. Next is hypersensitivity reactions. It is relatively more common with aspirin, less common with other NSAIDs. It includes skin rashes, urticaria, rhinitis, bronchospasm, angioneurotic edema, and rarely anaphylactoid reaction. Next is in people with G6PD deficiency, that is those individuals who are deficient in this enzyme, aspirin may cause hemolysis, and some other NSAIDs may also have the same potential of causing hemolysis in G6PD deficient individuals. Next is analgesic nephropathy. Again, all NSAIDs share this renal toxic profile, that is they are toxic to the kidneys, particularly on prolonged use. Prolonged use damages the kidney, resulting in renal failure. Next is Rees syndrome. Okay, this effect is only seen with aspirin. This is seen only in children, and when children with viral infections like chicken pox, like measles, okay, so when children with such viral infections, they are suffering from fever, when we use aspirin to reduce the fever, it produces, in some children, it produces fatty infiltration of liver along with encephalopathy, known as Rees syndrome. Pregnancy, yes, in pregnancy, aspirin may delay the onset of labor and it may lead to premature closure of ductus arteriosus. So that thing has to be kept in mind while aspirin is used when uh, pregnant lady goes into labor. Okay. Salicylism at high doses. So, see, I've already told you that the analgesic anti-inflammatory dose of aspirin is about 2 to 3 grams per day. So at such high doses, aspirin produces symptoms like headache, like tinnitus, vertigo, confusion, nausea, vomiting, sweating, diarrhea, etc. Now, this salicylism is only restricted to aspirin. Okay, it is not seen with other NSAIDs. Other NSAIDs are safe in this regards. And this salicylism is reversible when we remove the drug or when we stop the drug. The last adverse drug reaction is acute aspirin poisoning or acute salicylate poisoning. This is common in children who inadvertently take a large dose. Manifestations include nausea, vomiting, dehydration, acid-base imbalance, hyperpnea, confusion, coma, convulsions, cardiovascular collapse, and death. Okay, there is no specific antidote for salicylates. Okay, salicylate, there is no specific antidote. So only supportive therapy and symptomatic treatment of poisoning is given, and if the patient survives, then it's okay. Next is clinical use of NSAIDs. So where do we use NSAIDs? See, at the beginning of the lecture, I've already told that this is one of the most commonly prescribed group of drugs as an analgesic. Because pain is the most common symptom in clinical practice, this group of drugs, by relieving pain, they are one of the most commonly prescribed drugs. Pain could be of any nature. It could be inflammatory pain, that is, it could be due to trauma, it could be due to surgery, it could be due to musculoskeletal injury, it could be toothache, it could be any inflammatory process going on in the body. Any type of pain which is mild to moderate in nature, these group of drugs are drug of choice for relieving such kind of pain. As an antipyretic, yes, aspirin is not used. Other NSAIDs like paracetamol, they are the drug of choice for using as an antipyretic. Next group of uses, that is next some of the uses which I have mentioned are based on their anti-inflammatory effect. Rheumatoid arthritis, you know, is an autoimmune disorder where there is swelling of joints. Okay, so that inflammation of joints is there. That inflammation, that swelling is removed or reduced by NSAIDs. Okay, aspirin or other NSAIDs can be used. Please remember that these drugs are only symptomatic, it only produces symptomatic improvement. The ongoing disease process goes on, the disease progresses as it is. So other drugs are preferred, but symptomatic improvement is done by NSAIDs. Next is osteoarthritis. Again, it is a degenerative disorder of joint where there is swelling and pain in joint. NSAIDs are the drugs of choice for this particular condition. Gout, yes, in this condition there is deposition of uric acid crystals in the joint space, particularly in the joints of the uh, feet, okay, particularly the great toe. Okay, there is swelling, there is very severe pain. So NSAIDs are the drug of choice. They reduce inflammation, they reduce pain. And finally, in acute rheumatic fever, again aspirin is the drug of choice for acute rheumatic fever. The next use is, that is the thromboembolic disorder. Now this use is restricted only to aspirin because this use is based on its antiplatelet effect, and this antiplatelet effect is only manifested by aspirin, particularly at low doses, that is 75 to 325 milligrams per day dose. Low dose aspirin is used for prophylaxis of myocardial infarction and stroke. The other uses, now again the other uses are only for aspirin, and here aspirin mainly used in low doses. The first and foremost is medical closure of patent ductus arteriosus. Certain congenital anomalies include patent ductus arteriosus. In such newborn infants, the preferred drug is indomethacin. Indomethacin is given if it closes the ductus arteriosus, then it is good. Otherwise, it has to be surgically closed. Colon and rectal carcinoma prevention. Low dose aspirin has shown, studies have shown that low dose aspirin can prevent such carcinoma colon or rectal carcinoma. Then radiation induced diarrhea, yes, aspirin does because it is inflammation mediated. Prostaglandins are involved. Aspirin reduces such incidence. Controls pruritus and flushing associated with the use of nicotinic acid as an dyslipidemic agent. And finally, low dose aspirin can be used to prevent preeclampsia. Okay, so these are the clinical uses of NSAIDs. Now we will see the individual, some of the traditional individual NSAIDs as well as selective NSAIDs and paracetamol. Okay, so very few slides are there. Selective COX-2 inhibitors. Yes. So selective COX-2 inhibitors include etoricoxib, parecoxib, lumiracoxib. Okay, just hold on a second. Yes. So the selective COX-2 inhibitors, that includes etoricoxib, parecoxib, lumiracoxib. Now, how do they differ from the traditional NSAIDs or aspirin? Now, you can see that the selective COX-2 inhibitors like etoricoxib, parecoxib, they do not affect the stomach. Why? Because in stomach, the predominant COX enzyme is COX-1. It is not COX-2, and thus they are more friendly to the stomach. That is, they rarely cause GI irritation and peptic ulcer, while they are toxic to kidney, mainly the heart and kidney. In kidney, COX-2 is the uh, routine function enzyme. So here they inhibit COX-2 normally present in kidney, thus cause sodium and water retention, leads to edema. And in heart, they mainly inhibit the prostacyclin rather than inhibiting TXA2. So TXA2 is unaffected, and in the previous slides we have seen that TXA2 causes vasoconstriction, causes platelet aggregation. So it leads to thrombotic events in the cardiovascular system. So there is increased risk of myocardial infarction, increased chances of sudden cardiac death. So this is the limitation of COX-2 inhibitors. Next is paracetamol. It is effective by oral and parenteral route, well absorbed, widely distributed all over the body, is metabolized in the liver by sulfate and glucuronide conjugation, and these metabolites are excreted in urine. Where do we use paracetamol? Paracetamol is mainly used as an antipyretic agent. It is the antipyretic of choice for fever due to any cause and in any age. Okay, it has no aspirin like Reese syndrome risk. So it is the preferred antipyretic of any cause. Very well tolerated, very few side effects. It is used as an analgesic, okay, for common problems like toothache, headache, muscle pain, very commonly used. Adverse effects, side effects are mainly GI, okay, that is skin rashes and nausea, sometimes vomiting. Yes, the only problem with paracetamol is its tendency to cause hepatotoxicity with acute overdose or in paracetamol poisoning. And on long term, it has a potential to cause nephrotoxicity. Acute paracetamol poisoning. Acute overdosage mainly causes hepatotoxicity, the symptoms of which include nausea, vomiting, diarrhea, abdominal pain, hypoglycemia, and hypotension. Okay. Finally, death may occur if not treated due to hepatic necrosis. What is the mechanism of liver toxicity? The mechanism of liver toxicity is something like this. Okay. Paracetamol produces a toxic metabolite known as NAPQI. N-acetyl N-acetyl para benzoquinone. Okay. It binds to the proteins present in kidney and in the liver, leading to renal tubular necrosis and hepatic necrosis. Okay. N-acetyl parabenzoquinone or NAPQI. Now, normally what happens is that in normal doses, this metabolite is only produced in very small quantities, and in small quantities it combines with glutathione, which conjugates with this NAPQI and forms an inert inactive metabolite which does not damage the structures. Okay. But in poisoning cases, a large amount of NAPQI is produced. So the glutathione stores are depleted, and this NAPQI, now the unconjugated version, binds to proteins present in kidney and liver and damages this structure. So NAPQI is the molecule or the metabolite which causes this liver toxicity and kidney toxicity, and it is only seen in cases of large dose of poisoning. High doses of paracetamol causes depletion of glutathione. In the absence of glutathione, this toxic metabolite binds covalently with proteins in liver and kidneys and causes necrosis. By giving N-acetyl externally, by replenishing it, it replenishes the liver glutathione store, and it is the antidote for paracetamol poisoning. So to summarize, NSAIDs, they inhibit COX enzyme and thus inhibit prostaglandin synthesis. They all have analgesic, anti-inflammatory and antipyretic effect. They act peripherally and have no CNS side effects as well as depressive effect of CNS. Mainly, they all NSAID produce GI toxicity and nephrotoxicity. They are one of the most commonly used drugs for relieving pain, that is used as an analgesic. Thank you. In the next lecture, that is the second part of this lecture, I will discuss all other that is the all other traditional NSAIDs like aceclofenac, diclofenac, ibuprofen, and uh, others. Few slides are there, so a short lecture will be there. Thank you.